Hello, everyone. Thank you so much for joining today. My name is Jenna Groman. I'm the Director of Global Communities of Practice at Sabin Vaccine Institute, working with the BOOST community. And it's my pleasure to welcome you all to today's event, Strengthening Local Capacity to Apply Behavioral Science to Immunization Programs. This event is being hosted by the Behavioral Science for Immunization Network, which we will talk more about in a few minutes. Next slide, please. Before we get into the exciting part of today's event, just a few logistics and housekeeping items. Please keep your microphone on mute unless you are asking a question, but you can engage in dialogue with peers and the facilitators using the chat feature of the Zoom window. Please also use this chat to ask questions throughout the session. We will have time at the end of the session today to answer some of those questions and have a little bit of a conversation and hear how the speakers from today's event will answer those questions. So please make sure that you are continuing to share them throughout the event. You can also use the reaction button at the bottom of the screen to raise your hand during that Q&A session. Please, if you have not introduced yourself already in the chat, please share your name and where you are joining us from. Next slide. This event today is being hosted by the Behavioral Science for Immunization Network. This is a group of immunization practitioners and social and behavioral science experts who are looking at how to apply behavioral science tools, methods, and approaches to the delivery of immunization activities. We'll hear from some of these activities today, but if you'd love to join we'd love to have you all join the Behavioral Science for Immunization Network as well. You can join via Sabin's BOOST community by registering for the BOOST community and then selecting the Behavioral Science for Immunization Network as you register. And we'll put that link in the chat window for you. Next slide. And it is now my pleasure to introduce Lisa Oot from JSI, who will be talking specifically about today's event and introducing our speakers for today. Over to you, Lisa.
Hi, thanks, Jenna. We're really excited to have a great group here today and to talk about really kind of a culmination of the work that we've been doing in Nepal. So this is our third burst where we talked really about first introducing what is behavioral science, what are some tools and methods that you can apply to your work, and then here we are today able to present out results from the work that we've been doing. So we have three speakers today. So Leela Kanal, she is our technical lead. Swecha Shrestha, she is the UNICEF Nepal social science researcher who we're happy to have speaking with us today. And then Dr. Baraj Kamachara, who is with Kathmandu University School of Medical Sciences, and he is also representing Kathmandu University. We have a nice tripartite arrangement between JSI, UNICEF, and Kathmandu University. And so I will hand it over to our fabulous speakers and let them lead the presentation. So thank you. And please do write comments in the chat if you have them and we'll get to them. Thanks. Over to you guys. Leela, are you starting?
Oh,
yeah.
Sorry, I started. Thank you
No
so
problem.
much for the great opportunity. I'm so excited to share Nepal experience. And even I'm more excited since I saw the Steve Hodgins, my mentor and public health guru, to see participating here along with other colleagues from all over the world. It's a really exciting moment. Next slide, please. Actually, Disha had mentioned that, and we are working, this is kind of tri-party work we are doing between JSI and Sabin Vaccine Institute. And in Nepal, we do implement tri-party agreement with the Kathmandu University, UNICEF Nepal and JSI together, but under the Kathmandu University, we do have a big partner, Behavior Science Center partners. We'll talk about the more. And in the next slide. Next slide, please. And actually, let me tell my own story, why this is the Behavior Science Center. You have seen my intro also, and I have spent in the public health field around 30 years. And every time I work for maternal child health, innovations, scale up, and lots of things together. But whenever we do the study, go to the field, we always see the data. Okay, we do have a 80% coverage. We do have a 90% coverage. A village is fully immunization declaration. Whole country is kind of fully declaration. One day during COVID time, I went to the one community, and it's not a far, in one of the Tarai district. And I visited a community, and that community is around 45 households, and all were Dalit. And when first we went to the health facility, I met with the health facility management committee, ward chairpersons, and we were really looking for, and when we analyzed the data, we found that municipality have a many under dose and zero dose communities. But when we met with the health worker and community leaders, they said, no, we just declare our communities full immunization. We don't have any left out population. Wherever you got, that is the false information. And we are doing a great job. And they showed all the paper. And on the way coming back, one of the volunteer from the community, that was a community-based organization, and he said, no, ma'am, would you like to go to the one community where there are lots of underdose? And I said, let's go. It was not kind of very far. It was kind of 5 kilometers from that health facility. And then the community had a road head, and that was that community actually the Dalit community, and 45 household. Among that 45 household, well, they had only two wells, and all community household had a toilet. But that toilet had been used for the store. And because they are forced to make a toilet without water and without having the ownership. And basically, when we were kind of doing the human centered design, asking why they were not utilizing their toilet, and most of the answer is they don't have water. And even they don't know their female community health volunteer. They don't know what day that's the immunization day. And they were saying that none of the health worker or neither FCSU visited them. And at the same time, we found that 80% of their children are under immunized. And, and there are lots of zero dose, and more than 20% are zero dose, and 80% was under immunized. And we were really shocked, and we didn't have any answer. And they were so negative towards the health system, politics, and they think they were so discriminated, and they were unheard. And at the same time, I met with the lady, and she just called me, and she was listening our conversation. She called me, and she was 23 years old, and she married at the age of 12. She had already 5 kids, and three is alive, two is died, and she's already pregnant for 7 months. And her husband always go and work outside as a daily wages, and she never visited health facility for herself. And she went 2 times for her child immunization for the third child, but she didn't find the language barrier, and she found she was not well respected, discriminated, and she never went back to the health facility. Even when I talked to her, she said, she had a uterine prolapse, but she's pregnant. That tragic story is really kind of hurt me, and I thought we definitely need to do something in the behavior science. And basically, we always used to believe in the story from the health worker and female health worker and influencer, and we never realized that was not a mirror of the community. And this group know what to report and what is the different situation. That is again the recent example, what we are feeling this week and is recently this month is measles outbreak in the whole community, and where they declare full immunization 3 months back. This is just a background why we were excited to work for the behavior science immunization project. Especially our objective was to establish behavior science as a one door evidence generation and sharing, because we do have lots of evidence, but it was never used and shared in the governments. And especially when we wanted to share the evidence, not only this evidence generation, we want to use that evidence for the policy and planning. And when we use that evidence, we wanted to co-create a solution with the people, definitely like a community. I was talking about the ladies, I was talking about not involving only the influencer and health worker, and what our objective is to make a tailored solution for the community who the voice has not been heard, and they are neglected by the system, and they were never, nobody has reached them. And that's what we decided to do, that we needed to have a special program, behavior science intervention, using human-centered design tool, interpersonal communication, respectful care, using social behavior change. And definitely we just wanted to create a kind of platform where we can think for the mechanism together to reach to the unreached and to have the voice. And that was the objective, major objective, to establish the Behavior Science Center. Next slide, please. And especially before establishing the Behavior Science Center, even we did the scoping exercise. And when we did the scoping exercise, the 25 key policymaker, programmer, from the and even the service provider and behaviors, especially communication and social behavior change leading, working the different organizations, what we found, they didn't have enough variety of the behavior science, no structure beyond the National Health Education and Communication Center at the health sector. Especially people, most of the people have a limited understanding of the behavior science at the all sector of the government, including partners. And especially for them is just a communication and printing material and using the mass media. And, if you push the messages and problem solve, and nobody is thinking about kind of community perspective, social listening perspective, having a community voice and evidence for them. And even there was not a single platform to collect the evidence of the behavior science, analyze and provide feedback. Everybody was doing the research and using for their own purpose. And after that, there is no platform to archive, synthesize and provide the policy level feedback. And basically, and even we didn't found the clear recommendations and what the country want for the behavior context. And it was, most of the behavior intervention was done in the projectized, project based, and it was not institutionalized within the government system. And that's still most of the intervention was happened top-down approach rather than the human-centered design, and mass media used to be a solution for everything. That was the kind of, everybody thought like that. Next one. Especially this is a not long time we initiated the concept, and we kind of functionalized it. And Behavior Science Center has been established only last January 2022. And that was under the Kathmandu University. Dr. Biraj is leading that. We have a wonderful team working together, especially we have a partnership with UNICEF from the beginning. And especially Behavior Science Center is not only, even though KU is hosting that, but they have a government, different Ministry of Health and Ministry of Education and social scientists and civil society and the other UN agency, non-government and professional society, social scientists. There are the group of members we are working together. Especially primary goal of this Behavior Science Center is kind of creating the cross-learning and sharing opportunity across the stakeholder and program. And especially not only the kind of sharing opportunity, again, the strengthening capacity of the student, policymaker, programmer, and have a common understanding of the behavior science, and develop the common tools and use together. And especially another objective was gather social behavior insights that can be used during programming, planning, and implementation at the different sectors. And scaling up the best practices we have done in the different institution and country. And even we think whatever we have done, it has to be mainstreaming within the government system, and it has to be also included in the pre-service curriculum of master in public health and other nursing curriculum. Next, please. And so far, and our within a list, just 1 year, we had a few progress. Like we conducted the scoping exercise, we have established the Behavior Science Center, and we have already done the desk review on the vaccine confidence, especially in taking the 2 indicator routine immunization and COVID vaccine. And based on that, we conducted the formative research, especially to identify the behavior driver that contributed low vaccine uptake, and using socio-ecological model, and even we use that journey to health map. We use that's a human-centered design, and even we mainstreaming the behavior science center within the government. That means we developed IPC manual, SPC manual, and even SCT manual, and it has already accreditation and mainstreaming the National Health Training Center. We had to build the capacity of the behavior, different partners like Behavior Science Center members of the Kathmandu University, National Health Research Council, National Health Training Center, and other provincial level government also. And we do have we have this finding from the formative research. My colleague Sweta will talk about more. And even based on the finding, we co-design the solution, implementation research, and co-design the solution together with the community. And we'll talk more on the next slide. And good things for us, within the short period of time, the role of the Behavior Science Center has been well acknowledged by the government. And whenever government wanted to do the behavior intervention discussions, behavior science, especially Dr. Biraz and team is always invited to talk about that. Especially now we are having the measles outbreak in that one of the response. First thing they requested Behavior Science Center to come and support to identify the causes and behavior barrier and to immediate response. And that was kind of for us, that's a pride moment. And even now we are in the different planning process, different project is developing the 5 years country program. And there is a long-term plan is being developed by UNICEF. And similarly, government is also developing the roadmap of the social behavior change. And behavior work has been well recognized, and especially continued study of the behaviors and need has been clearly acknowledged, and it has been one of the highlighted action plans by the different organizations. Next one, please. Okay, over to Sweta, and I would request her to go from here. Thank you so much.
Thank you, Leela-Dee, for the handover. And I'd like firstly to thank the organizing team for having me here as a speaker today. So just to move forward with the slides, as Leela-Dee shared a story which was very touching, to explore similar and unheard, untouched stories from the community, we conducted a formative research. So the formative research, it was one of the major activity conducted by the Behavior Science for evidence generation. The behavioral and social factors associated with the routine immunization and COVID-19 uptake. So this was conducted among the caregivers and community members in the selected wards across 3 provinces of Nepal. So in this, we used tools from the human-centered design process, and the rapid inquiry as well. So this study, it also presented us as an opportunity to strengthen the capacity of the behavioral science members and the members from Kathmandu University as well. So we use some kind of a learning by doing approach, where we also trained the research assistants and the behavioral science members in the human-centered design, the COMBI model, and the journey to health map as well. Next slide, please. So I'll just quickly run through this flow chart. So the process, if you just look at the bottom of the flow chart, the process helped us to identify the households, the caregiver, and the influencers participating in the study. So this was quite a rigorous process, where we first looked at the secondary data via the HMIS with multiple consultation with the government stakeholders and the local level stakeholders, which we identified the study areas with the lowest vaccine uptake. So the data was further triangulated with community verification to finally identify the target group. Next slide, please. And so this slide, it shows, Aisha, if you go one more click. Thank you. So this slide shows the socio-ethnographic approaches used during the process. The first picture shows choreography. So choreography is a bit of contextualized way or a contextualized method of ethnography, especially used in Nepal, where we use like an informal, unstructured conversation with people within the community, where questions automatically emerge in a very natural course of conversation and no set of questionnaires is used. If you look at the second picture, we use snowballing and also like a observation with clues, where we looked at toddler clothes hanging out to dry to identify the households of under 2 children. And the last picture, the transit walk, it shows like it's a participatory tool where we aim to observe geography and everyday walks of life in the given study area. And for the data analysis and data synthesis, we used the Journey to Health tool, which I'll talk a bit more on the next slide. It explores the 6 dimensions of how the service utilization happens from both the caregivers and the service provider side. Next slide, please. Okay, so I'll just ask Aisha to just quickly click through the slide. So we use this the Journey to Health framework to actually analyze the data or the stories we got through data collection. So it shows 6 stages of how a caregiver's journey happens through health and immunization or health service seeking behavior. And this framework, it not only talks about or explores knowledge awareness, but it goes beyond that. And as you can see, this is like in a figure 8, which means it's in infinity. So each stage is infinity. Okay, and as you can see, for each stage, we've got pink and yellow stickers. So the yellow ones show the enablers for each stage, and the pink one, it shows the barriers. Okay, and for the next slide, please. And for this one, this shows the key behaviors of what we found out in the formative research. So the major findings were that the floating population or 0 dose population belong to the under or 0 dose children belong to the floating population. The other thing was the health workers, they did not take accountability of these migrant population. The caregivers, they experience discriminatory behavior from the health workers, and the service seekers, they also returned from the health facility without getting any vaccines due to lost or missing vaccine cards. The other major findings from this study was that women who were the primary caregivers, they have very limited decision-making power, making it very difficult for them to take their children to get vaccinated. And the last one was the caregivers, they were unaware about the location, service hours of the immunization sites. Next slide, please. So this followed the findings of the formative research was shared with the behavioral science members, the ward officials, health workers, and senior public health officers. So this followed, the formative research followed an implementation research was done. And as one of the starting activities, an ideation workshop was conducted to co-create solutions with the communities. And when we say communities, we included community representatives, the end users, service providers from basically 2 wards of Kathmandu. And after the co-creation had been conducted, activities such as household profiling of the under 2 children was conducted with the KU, the Kathmandu University team, along with the support of the FCH. Next slide, please. And when we talk about what we did as an intervention for the implementation research, it was focused on addressing the gaps that was identified in the formative research. So the first one, as we can see, that we provided training for the female community health volunteers and health workers on HCD, SPC, and interpersonal communication with a focus on with respectful care and counseling. So this one, it attempted to address the discriminatory behavior of the health workers that was experienced by the caregivers. The second one says the monitoring, follow-up, on-site coaching. So this one attempted to ensure skills were actually utilized that was given from the training during service provision. The last one, it says the orientation and training on the national immunization guideline. So this guided the health workers actually to improve and align the service according to the latest national guidelines and current national guidelines. Next slide, please. So we further did some, we further provided some home-based counseling, which was actually focused on male engagement. As fathers, they were not as much involved in their children's vaccine-seeking behavior. The next one is shared information on the importance of home-based records. This is mainly the vaccine cards and the retention of vaccine cards to both male and female caregivers, and provided these information on the immunization clinic, where they are, their operation hours, and what's their nearest service sites. Next slide, please. So we, as part of what we do as a behavioral science center, we conducted multiple trainings for capacity building, and this is just some pictures of when we conducted the training sessions. Thank you. That's all from my side. I'd like to hand this over to Dr. Biraj now. Thank you.
Yeah, thank you, Leela ma'am and Swaksha ma'am. So, hello everyone. Thanks for this opportunity. I think Leela ma'am and Swaksha ma'am have very nicely explained the background of the center, and also some of the activities that we've managed to implement in the last year. I will briefly highlight upon the next steps that we are aiming for. One thing that has come up very nice in this experience is that this unique partnership between academia, which is Kathmandu University, different government bodies, and UNICEF and JSI, and also other stakeholders, has proven to be a very innovative model of creating something like this. As Leela mentioned, it is housed within the academia, within Kathmandu University. So, in that way, there is quite a bit of stability and an approach to sustainability of this center. And through the works that we have been able to accomplish in the last year, what we have felt and managed to even persuade the government stakeholders is that as a center, we come in and support the efforts of the government in a more complementary fashion. So as the next steps, we plan to expand the scope of our activities. We have started this primarily focusing around the vaccination issues in some of the hard-to-reach communities. And strangely, we started from the capital itself, Kathmandu, the city of Kathmandu, and we found that there were communities that had major challenges with vaccinations. But we didn't limit only in the city. We also started some works in other rural sites of the country. So some of these activities have been acknowledged very well by the stakeholders, and people have started to see that this really can be a model of success that can be expanded not just in the vaccination but also in other aspects of health programs. In fact, there are already discussions underway in which we've been asked if we could support in the behavioral components around programs related to nutrition, non-communicable diseases, and so on. So we'll be strengthening the current activities, expanding the scope of the current activities in terms of the discipline as well as in terms of the communities that will be involved in coming days. We are also, very mindful of the fact that if we do not, adopt scientific methods and incorporate the rigor of research within our programs, then it would be very hard, to replicate these works and disseminate these works in larger communities. So we're trying our best to structure our activities around research point of view as well as implementation research, and we have been working around the documentation and also publication of various forms so that we could share the findings to different audience, not just to the scientific and technical audience, but also to policymakers and also people who are working on the ground level, in behavior science related activities. We are actively engaged with policymakers and program leaders from the government in all the different tiers of the government. Nepal has recently had a major restructuring of its health system, where we have a federal government, which is a central government, then there is a provincial government, and there is also local government. So all of these three tiers of the government have their unique responsibilities, and we are navigating our way to engage all of these governmental entities to adopt behavior science related approaches. We're also working in dissemination to other stakeholders and partners, which includes academic partners, development partners as well, and we're continuing to scale up similar activities in other settings as well. There's already a discussion underway in which we have been asked if we could create smaller groups and expand our activities to wider settings in the country. Next slide, please. Just a couple of weeks back, there was a measles outbreak in the western part of Nepal, and immediately our team, led by Suraksha, who is also in the call today, they visited the site, and immediately they collaborated with the government, local stakeholders, and also the communities in handling the outbreak. And this was quite an experience for us also, and also for others who were closely observing our activities, because the major role that we had was to utilize all the behavior science related knowledge and experience to ensure ensure that the communities that have not been, vaccinated come for vaccination and will follow remaining vaccination schedules as well. So the teams have been doing fantastic job, and they're working on the ground now as well. One thing that I also want to focus is that one of the major motivations as somebody from academia and for hosting this this center and also being a part of this center is we really want the trainings and the knowledge related to behavior science to be incorporated into various health sciences curriculum. We recently had a training of all the students of our Masters of Science in Public Health in our university on human-centered design and interpersonal communication, and we're working to embed the behavior science related capacity building programs as elective courses, and hopefully in near future we can start dedicated master's as well as PhD level track around behavior science. We will also be working in proposing to other academic institutions similar efforts, because what we believe is that if we can instill these skills in the new generation of public health and health sciences professionals in the long run, that's the best way to permeate the field of public health with very top class knowledge and skills related to behavior science. And thank you very much. So this is all I have. I'd be happy to answer questions. Thank you.
Hi.
Yeah, these are, I forgot this. These are some pictures just taken last week that show some of our colleagues from the Behavior Science Center working directly in the communities and also working with local stakeholders to respond to the measles outbreak. Yeah.
These are great pictures. Thank you everyone for sharing. Jenna, do you want to do last slides, or do we want to dive into questions for a bit?
Let's do Q&A first.
Okay, great. So I was reading through the chat, and there's some great questions that I thought would be good for to hear, for the whole group to hear your responses. So I pulled them out of the chat, and so I think you've actually just kind of talked a little bit about this, Dr. Baraj, but I wonder if Leela, maybe I'll direct this to you first. If you could talk about examples of how behavioral science recommendations or interventions have then been implemented at scale. And do we have any examples of behavioral science recommendations, interventions that have been implemented at scale in Nepal?
Thank you. And main thing is the Behavior Science Center has done a formative research. And based on that, they were saying that that was a clear recommendation that urban floating population and even in the municipality, they have been left out. With that recommendation, and especially Ministry of Health, as well as the Department of the Health has done a quick, intervention. They mobilize their female community health volunteer, and they mobilize their health worker. And for them, they never realized that within the Kathmandu Valley and within the big municipality, many people had been missed. And especially what we were thinking, will give kind of, once we have that data, we share the data, inviting the Kathmandu municipality people, ward level health worker, and all stakeholders. When we share the presentation, and we were planning to do the implementation research before we initiated and come with the idea of the implementation. They did their in-house meeting, though they mobilized the FCSB, they have interacted with the health worker, and there was a few findings. Exactly. First was many people were saying that especially immunizations time, and they always do in the immunization session in the day. But daytime, most of the labor, that's migrant are the labor workers, they needed to go for the work. That time was not convenient. And when we shared that recommendation, and the government decided to have the session, especially in the morning or evening in their convenient time, and they did it actually. And even there were the questions, there was the finding, people had to return without vaccination card, and they provided enough vaccination card with the counseling. And another things, and even we provided training, and we didn't do along ourselves, we did with the government. And when we were doing together, and initial in our study, there was lots of zero dose and under immunized. During this period, already they have already immunized with the intervention. You know, that's what I not only that one, that was kind of a tease, kind of tips of the iceberg, and that was the example always taken by the Ministry of Health whenever there was immunizations planning meeting. That recommendation has been implemented, and even the work plan, government is making a work plan, and they have definitely thinking to revisit their short-time immunization strategy. Are they really doing the short-time immunization well, even though it is a in the paper, and they, even the Ministry of Health and Department of Health has circulated throughout their channel, and our program needed to revisit, because even though you are saying that short-time immunization is happening, but there are evidence are coming not only from this study, another study we did with the National Health Research Council. Similar finding came, like many targeted community has been missed. Government has sent a special circulations, and they requested for an targeted intervention. So many things has been already addressed, and through the government and partners.
Thank you, Leela. There was another question, and maybe I'll direct this towards Swecha, questions around how long were the interventions implemented for, and if we have results yet, and also our plans around measurement for the implementation.
Thank you for the question. So we're just at the end of the implementation process now. And so we conducted the implementation research in 2 comparable wards in Kathmandu. So they were small study areas which had similar situations. So the implementation, the interventions conducted in 1 ward was successful. Comparatively, in the other ward, we had some challenges. For example, I'll just give an example to clarify that. The IPC training, the HCD training, and the SPC training. So the interpersonal communication training among the health workers, it was turned out to be very successful in one of the wards, as the health workers were more motivated, and they conducted home visits. They brought more children to the vaccination sites, and they really internalized that it was important and to improve respectful behavior and respectful care during their service provision. However, when we did, I think there was another question on how we were looking at the pre-test and post-training improvements in the behavior of the health workers. So in the other ward, we also saw that while doing the client exit interviews and observation during service provision, some health workers, they had not yet internalized that respectful care, or providing counseling, the entire proper counseling about after effects of vaccinations, about vaccination cards, and the importance of vaccination. They were not doing it entirely, and they were just doing it for the sake of us, because some of the team members were present there as an observing partners. So it was kind of a challenge where we realized that once just doing the intervention once in that area is not going to bring up that change. So social behavior change is an iterative process. We have to do it multiple times to have them internalize it as well. So yeah.
So I'm going to ask Adefunke if she wants to come off mute and ask a question. And then there were several questions around care workers not feeling accountable for certain populations. So maybe we can come back to that question after we hear from Adefunke. Do you want to come off mute?
Yeah, thank you so much, Lisa. I really appreciate. Thank for the organizers and the presenters of this. You have actually done a great work and an insight to every one of us, the healthcare professional. My question is this: for the first presenter to go to Zil, I would like you to expatiate more on what you call choreography. The choreography, is there any way different from our normal community key informant interview or focus group discussion? One. Secondly, my questions again is that I didn't really, or probably I missed something, but I've not left my laptop since. I've not really seen the tracking as in monitoring of this project, because it's actually going to add a lot of things to the project in total. By and large, I would like to thank every one of you. Then my third question is about discrimination. There should be a research carried out on that area, because it's going to have a tremendous negative effect on the total immunization coverage and the healthcare performance generally in that region. Because don't let us forget, healthcare workers, they are key in this concept. Thank you.
Okay, two long questions. I'll try to answer. And basically, your first questions was, what is different choreography and other, kind of other qualitative research? And choreography is, especially for the behavior studies, Kura is kind of talk, graphy is just an approach. It's just a choreography is a Nepali word, actually. It's kind of informal talk. And most of the time when you go to the community, as a stranger, go to the formal setting and do the kind of interview, kind of FTD, they might give all kind of ready-made answer, might not come real inside. And if you go and be in the community, throw the issue during tea shop, and while people are gathering, talking, a very informal setting where you will be like the community, you throw the issues, you listen to their things. And if you, choreography is more informal approach to have a real insight. Like before I initiate the discussion, I said that most of the time people will give a story which might not be the true by heart. They know what to say and what to do. And for the choreography, you'll know the different view, even though it's not kind of, you can't write it, record it, but definitely that is the insight you'll get from the community. And that is the approach. Another, you said for the second question, for the monitoring, and we have before we go for the intervention, we have a whole community profile. Especially we have a baseline as a community profile to identify how many children have been missed for the immunization, what are the reasons, and then there are the set of questionnaire. And even during even we use the CAP model, and even for the base midline we did that, and even to see the health worker attitude to change, we use the client exit interview, and even we use the observation checklist. And during this vaccination site to see and the behavior counseling difference between before, between, and after our intervention. We have a set of monitoring tool has been developed and implemented. For your third question is about the discriminations. And basically what we found that, and throughout the interventions, people, especially from the poor and marginalized, And they said we have been discriminated. And when we basically, this is human-centered design approach, we had to see and analyze the problem both from the service provider side as well as the caregiver perspective. Sometimes it's a language barrier, sometimes it's overburden of the health worker, and sometimes it's and caregiver service caregiver is too busy and they wanted because they had to go and work for them. They always want they don't wanted to have a long time to wait for the, they want a quick service, which is not always possible. There is always two sides of the coin, but definitely to minimize the discrimination, and we definitely have a all those story we share with the service provider. We try to discuss and dig down the reason and came with the solution. It is whole process was very iterative, and our researchers went back to the same health facility with the same health work more than 10 times. 10 times. They went to the same mothers many times. And if they said, I'm not the one who doesn't want to have a vaccine, but my husband didn't allow me to go for the vaccination. Again, our team went and discussed with the husband and father why it happened and what was the, even we found, and we found husband was not a really barrier. Actually, he was not on aware about the importance of the vaccination. He was kind of labor working, and he never had any, he didn't have any source of information. He thought it's okay not to have a vaccination. It's not a problem of father again. It's problem of the whole system of the access, poverty, and that's a competing priority of the survival in terms of the protection. That's the whole social dynamics rather than the one issue.
Thank you so much, Lila. Thank you. But I would advise that what you have just explained on the concept of tracking, the way you really wanted to, or you have tracked the work, should also be itemized and probably documented and be embedded in your documentation. Thank you.
We have done that. We're happy to share. We have published some of the document already. We'll be happy to share with the link to the team. And
all right.
We are waiting for the main report, but we have already summary finding report of the different work. We're happy to share it.
Thank you so much. Thank you.
Yep.
Thank you. Well done.
Absolutely. Thank you. And I'll just say, I think what we're finding in Nepal and urban areas is likely a problem in many countries throughout the world, in urban centers where there's a lot of migration. Health workers are working with populations that are different from them, maybe don't speak the language, cultural barriers. So as to say, I think this is really important to be able to use this information to really dig down and understand some of these issues, and behavioral science certainly provides a great opportunity to do that. So we are closing time, so if we haven't answered your question, we'll try to do that. We'll capture the comments and questions and send them out via email to those who are interested. And I'm going to just turn over to Jenna to close us out.
Thank you, Lisa. Next slide. And as Lisa said, we will follow up with the speakers and share out additional responses to all of the questions that have been asked. I know there's been a lot of really great questions that have come in throughout today's session. We're excited about that. So what's next following today's event? First, we will follow up with the slides and recording of today's event, along with the additional responses from the speakers to respond to those questions. But we also would love to have you join the Behavioral Science for Immunization Network through the BOOST community, as we talked about a little bit earlier. This will allow you to share feedback both on today's session, to talk to peers about how you are using behavioral science to address immunization challenges, explore resources, and discover additional events. We'd also love if you took our survey from today's event to share your feedback. Let us know what you learned and how you plan on using this information. And next slide. And we also have one additional event coming up in just 2 weeks. We hope you can join us on February 2nd as well. The registration link will be in the chat window. And this event will be coming from the Ghana team, and they'll be talking about applying human-centered design to the COVID-19 microplanning process. So we hope to see you again then. We thank you all for joining today's session and for the many thoughtful comments and questions you've asked. Thank you especially to our speakers today for sharing your experience and what you've learned through this work. And we look forward to speaking with you again soon. Have a great rest of your day.
Thank you.
Thank you very much.
Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you.